aneurysm, I'll also discuss about vasculitis. See, if you look at your CBMA curriculum, vasculitis is not something which is mentioned and which is emphasized in your CBMA curriculum, but I'll definitely go and talk about vasculitis. The only reason that when you go to your third year or final year, there will be lots of case scenarios in your competitive exams which can come with respect to vasculitis, right? Okay, good evening Sunanda, good evening Bhavani, good evening Aslam, good evening Tina, fine. That's the only reason I wanted to take both vasculitis as well as aneurysm together. We'll focus more on aneurysm and the complications of aneurysm because that's there as a part of your CBME curriculum. And definitely I'll talk about vasculitis, how to diagnose them. Whenever you come to your clinical postings, be it your medicine or pediatrics, you might see quite a few vasculitis. At that time, I want you to correlate and make sure you have a basic understanding of vasculitis here so that you can build on your concepts when you go to your final year and pre-final year, fine? Okay. Rahul, Bioja's disease is a vasculitis. We'll definitely talk about it when we go to vasculitis. Fine. Good evening, Vidhi. Good evening, Sajat. Fine. Okay, now let's go to aneurysm. Fine. So how we are going to structure aneurysm is, it is definitely one of the complications of atherosclerosis, right? There are multiple other things which can also cause aneurysm. Not just your atherosclerosis. You can have traumatic aneurysm. You can have hypertension-induced aneurysm. You can have infectious cause of aneurysm, right? So first we'll classify aneurysm. Then we'll go with different causes of aneurysm. We'll broadly categorize them into atherosclerotic related and other related, and then there's one more complication of aneurysm which is dissection. We'll see that as well, fine? So we'll take aneurysm in general. This classification, what I'm going to talk is about an anatomical classification. Okay, so we have two types of aneurysm, right? So when I call it an aneurysm, it's an outpouching. That's what aneurysm basically means. It's outpouching of the vessel wall is caused an aneurysm. The outpouching can be one side like this, or I can have both sides outpouching, fine? It's fine with you. We'll definitely take care of this. See, if I miss something in DPP, it's okay. The purpose of DPP is to make sure you solve questions. You have come outside the 12th standard, so definitely when you sit in an exam, you might have a new disease totally, right? You have to get used to it. You will definitely get used to it, right? There are two types of anatomic classification of aneurysm. One is saccular, right? We call this saccular aneurysm, and we call this fusiform aneurysm. As such, I don't have any clinical importance for these. Like saccular means good prognosis or fusiform bad prognosis, doesn't mean like that. It's just an anatomical classification. Whenever you read something like an anatomical classification without a clinical correlation, you need not remember much. Maybe in Viva it will be helpful. When you go to radiology, you can see the appearance, saccular and fusiform. But patient management, this thing is not important for me at all, right? At the same time, I have one more classification of aneurysm. Have you heard about Meckel's diverticulum? You have? You must have heard about Meckel's diverticulum, right? So when you read about diverticulum, there are actually two types of diverticulum. One is called as a pseudo diverticulum, and the other one is true diverticulum. What do you think is Meckel's diverticulum, pseudo or true? We have quite a few classifications like that. Diverticulum also we classify as pseudo and true. Aneurysm also we classify them as pseudo aneurysm and a true aneurysm. Fine. We'll see what does a pseudo aneurysm mean, and also we'll see what does a true aneurysm mean. When you take true aneurysm, the wall of the aneurysm will have all three layers. That's what is called as true aneurysm. Same with diverticula. When I have a diverticula, if it has all the layers of the intestine in the wall, I call it a true diverticula. The same thing holds true for aneurysm as well. When I say I'm having a bulge here, it has all the three layers. I'm ignoring the internal elastic lamina and external elastic lamina here. Three layers means tunica, media, adventitia, and intima. All three layers, right? If the wall has all three layers, you call it a true aneurysm. Right? True divertical also mean the same. True aneurysm also means the same. So what do we call it as pseudo aneurysm, right? So when do we use something pseudo or a false aneurysm, right? Which means it's clear cut saying that the wall does not have all three layers. So what does it have? So what is actually, is it an aneurysm or something else, right? That's what we're going to see here. Let's say I'm having a vessel wall where I'm having a vessel wall rupture. Tell me, if there's generally a vessel wall rupture, what will happen? If a vessel wall ruptures in general, what do you think will happen? Any vessel wall when ruptures, what do you think will happen? It automatically will result in bleeding, right? It will result in bleeding and then a clot formation happens, right? So let's assume this injury to the vessel wall is very, very subtle. Not a very big injury, very tiny injury. Is there a possibility, I'm just zooming it here, is there a possibility the blood in the lumen can slowly leak outside, and this blood can be contained by the perivascular tissue. I'll use a different color for the perivascular tissue. Let's say this is my perivascular tissue. Okay, so it's your perivascular tissue. The perivascular tissue here is going to contain the blood, right? Normally in an injury, the blood vessel ruptures, bleeding will happen. You cut, it will bleed. But there are at times there is an injury, bleeding might not happen. This perivascular tissue will contain the blood. So what happens is, here I'll have a clot formation, right? So clot forms here. Now this clot, when you look from the outside, does it look like a bulge on the vessel wall? It does, right? So clinically for me, it looks like an aneurysm, but actually it's not an aneurysm. It's nothing but a perivascular hematoma, right? It's nothing but a perivascular hematoma. That's what we call it a pseudoaneurysm. It's a clot formation just outside the blood vessel. We call it a pseudoaneurysm, right? Next question is, where do you see this? Do you know what is the term used when you tie two blood vessels? What's the term used when you suture two blood vessels? Have you heard the term called as anastomosis? Have you? You must have heard the term called as anastomosis, right? So when you have anastomosis, what happens is, I have two blood vessels here. I'll put a needle. I'll take a bite. Bite means suture, right? You take a bite and then you suture it. So when I take a bite, I have to take a prick from inside the blood vessel. Can it injure the layers of the blood vessel? It can, right? So when you suture, my needle goes like this and then it sutures here, right? This is how suture happens. I'll erase this, but this is how suture is going to happen. So whenever there's a suture, there's definitely a possibility the vessel wall can be injured. But it's a tiny thin needle. It might not bleed, but slowly blood can seep and get collected in the perivascular space and causing perivascular hematoma, right? So that's one of the major cause of pseudoaneurysm. One, at the anastomotic site. Okay, at the site of anastomosis. Okay, I'll repeat it, Rahul. At the site of anastomosis, see, when you suture a vessel, this is how a vessel is going to be, right? I'm having a vessel here. I'm having one more vessel here. I need to suture them. So when I have to suture, a needle should pass through this. Only then the thread will automatically bring it close together and it will suture, right? So when the needle passes through the wall or the suture material passes through the wall, is there a possibility tiny amount of blood can leak from this place? It can, right? So that leak will get contained by the perivascular tissue and forms a hematoma here. So when I look from the outside, it looks like a bulge at the site of anastomosis. We call that a pseudoaneurysm, right? I hope it's clear, Rahul. That's one part. Second part, myocardial infarction. Let's assume this is a heart. Okay? Myocardial infarction means the entire layer of the myocardium is destroyed or dead. That's what infarction means, right? Let's assume this is the heart wall and this entire part is dead, right? Okay, this entire part here is dead here. What is this? That's your lumen, right? Here definitely blood will be there. When the entire myocardium is dead, is there a possibility the overlying endocardium can also be injured? Am I right in saying that? Definitely there is a possibility overlying endocardium also can be injured, right? So ultimately it is a dead tissue. Again, is there a possibility the blood from the lumen can slowly go outside? Because the entire tissue here is dead, gone. So there is a possibility that blood can go outside. But the pericardium here is intact, right? So what happens here is my pericardium here is intact. So slowly blood comes and collects here. So this is an post-MI aneurysm. The blood slowly leaks, collects in the pericardial space, and we call it an post-MI ventricular aneurysm, right? So post-MI aneurysm, post-myocardial infarction aneurysm, and aneurysm at anastomotic site are possibly pseudoaneurysm. I'm not saying that these are the only possibility. Simple words, if the aneurysmal wall or the bulge is not having all three layers, I call it pseudo. If it has all three layers, I call it true aneurysm. That's all fine. So these are two major classifications of aneurysm based on the wall of the aneurysmal site, fine. True as well as pseudo. And we also have anatomical classification, your fusiform as well as your saccular aneurysm, right? Which part you want me to repeat, Rahul? The MI? This is a muscle. This is a ventricular muscle here. This black color is dead. The black color is completely dead. Obviously the blood from the lumen can seep slowly and go outside because the entire muscle wall here is dead. So the blood from here will go outside, but my pericardium is still intact because it's myocardial infarction, right? Since pericardium is fine, the slowly coming out blood will form a clot here, which looks like a bulge when I look from outside. So it's called as a post-MI ventricular aneurysm, fine? Okay. So these are few examples of true and pseudo aneurysm, right? So now we know about aneurysm. Now look at the common cause of aneurysm, right? Anywhere, the common cause of aneurysm anywhere in my body, it's going to be atherosclerosis. There are few exceptions. We look at it. When I say descending aorta, arch of aorta, abdomen aorta, renal artery, or your splanchnic circulation, CNS, any vessel, the most common cause of aneurysm is atherosclerosis. That's one for sure, right? I'll come to it, Sajat. I'll come to that. There are a few exceptions. The most common, overall, the most common cause of any part of my body is atherosclerosis. The exceptions come here is when you take ascending aorta. I want you to remember a few things. When you take ascending aorta, there are two causes which is common. One is hypertension, which is common in ascending aorta, and syphilis. Okay. Syphilis is also common in ascending aorta, right? Which of these two do you think is most common? If a question comes, what's the most common etiology of ascending aorta aneurysm, and you have both hypertension and syphilis, what do you think is more common? Hypertension or syphilis? Undoubtedly hypertension, right? You should never have a doubt in this. Hypertension is undoubtedly more common. Syphilis almost long gone, right? I might have few rare questions, but syphilis also affects ascending aorta. I'll give you a logic why syphilis as well as hypertension affects ascending aorta. Just give me a second, right? When you take popliteal or in peripheral artery, okay, most of the peripheral arteries, like a radial artery, it's very unlikely for atherosclerosis to happen in radial artery. Trauma can happen more commonly, like such as for popliteal artery aneurysm. Trauma is more common than anything in peripheral artery, right? If it's a peripheral artery aneurysm, traumatic aneurysm is definitely more common than the other cause, right? So these are in general about the etiology and incidence of aneurysm in different parts of the body, right? Now, we just read yesterday that 3 different types of arteriosclerosis, and I told in one of the types, hypertension is the cause. Which type hypertension was the cause? We read 3 types: athero, arterio, and arteriolo. Which type hypertension is the most common cause? Arteriolosclerosis, right? So arteriolosclerosis, I said that hypertension is one of the important cause of arteriolosclerosis, right? Now let's look at the heart. Heart is definitely the biggest vessel in my body. From heart, my aorta originates. So heart in the myocardium, the muscle of the heart, am I right in saying that they have penetrating vessels? Is that statement right? The myocardium will have penetrating vessels from your coronary circulation, right? Obviously right. So when it becomes aorta, there's a sudden drastic change. Aorta, do they have penetrating vessels or they have vasa vasorum? It's aorta. Will there be penetrating vessel or vasa vasorum? They'll have vasa vasorum because it's a vessel, right? Vessels cannot have penetrating vessels. It has to have vasa vasorum only, right? So now what happens is when I take heart here, in heart, I'll have lots of penetrating vessels here. From heart, let's assume my arch of aorta is joining. So there's a drastic change in this part. From a penetrating vessel here, I'm having vasa vasorum, right? If this statement is true, for me to survive in the ascending part of aorta, am I right in saying that the density of vasa vasorum will be more because it's trying to adapt from heart to your ascending aorta, right? So in my ascending aorta, the vasa vasorum density is very high. When the vasa vasorum density is more, because it's adapting from a penetrating vessel to vasa vasorum, so the density has to be more, right? So now, can I say vasa vasorum is an arteriole? Very tiny vessel, right? So if a patient has hypertension, am I right in saying that the entire vasa vasorum will become obliterated because of arteriolosclerosis? Whatever it is, atherosclerosis or arteriolosclerosis, what will happen to the lumen? Smaller, bigger? It will become smaller, right? So when a person has hypertension for a very long term, this vasa vasorum becomes smaller. When it becomes smaller, the wall of the aorta dies. When the wall of the aorta dies, is there a possibility of having aneurysm? There is, right? So the reason I'm just giving you reasoning why hypertension is more common in ascending aorta, you need not memorize, because in hypertension, vasa vasorum is going to undergo stenosis because of arteriolosclerosis. That's all. Okay, because of arteriolosclerosis, it undergoes stenosis. That's all. If it undergoes stenosis, definitely there's more chance of ascending aorta being affected. When it becomes arch or descending aorta, the density of vasa vasorum distributes. So it's not very severe to have an aneurysm, but ascending aorta definitely can cause aneurysm. Fine. Okay. So now we know different types of aneurysm and different cause in your different parts of the body, right? One important thing for me is abdomen aortic aneurysm, right? All the good doctor fans, there are, or your Grey's Anatomy, there are quite a few places the patient will come running to the hospital and you'll be like, there's an abdomen aortic aneurysm rupture. We will save the patient, right? Yes. Rahul, you want why arch of aorta is not having hypertension? Is that the question? Why hypertension is not causing arch of aorta aneurysm? Okay, so if you see, like, there's a character in Good Doctor, I forgot his name, tiny Jew boy. His first patient will be abdomen aortic aneurysm, and he will miss it and it will rupture, right? Okay, see, atherosclerosis will weaken the vessel wall. We read about atherosclerosis yesterday. When it weakens the vessel wall, it will definitely cause aortic aneurysm, or any vessel where it's going to be involved, it will cause aortic aneurysm, fine? It will cause aneurysm of that particular vessel because it weakens the wall of the vessel, fine? Now I'll come to abdomen aortic aneurysm. The reason why abdomen aortic aneurysm is emphasized for an undergraduate is you will be the first person who will be examining these patients. They come in emergency. You should not miss these. Anything when it's pulsatile in the abdomen, please refer to the surgeon immediately. Pulsatile mass in the abdomen should never be missed because it's an aneurysm, a dilated one, right? Atherosclerosis doesn't spread. Can you rephrase your question, Rahul? It's a dilated wall of the vessel. Is there a possibility it can rupture? Dr. Asher. Is there a possibility it can rupture? It can. Imagine an abdomen aorta undergoing rupture. Can you save the patient? Even in Good Doctor, they cannot save the patient. It's impossible to save my patient if the abdomen aorta ruptures or aorta ruptures in any point of time, right? It's very, very difficult for me to save the patient. So for an undergraduate, when you see an abdomen mass which is pulsatile, I want you to wait, carefully examine. Please, please, please refer to the surgeon at the earliest, because I have to treat it before it undergoes rupture, because if it undergoes rupture, it's gone, right? Abdomen aortic aneurysm is one of the commonest site of aortic aneurysm. Again, the cause is definitely atherosclerosis, right? Was undoubtedly atherosclerosis. Okay, I do have multiple other causes. We'll go one by one cause, right? So abdomen aortic aneurysm, as usual, we know our only goal is to diagnose patient, treat patient. We have to look at the pathogenesis. We have to look at the clinical examination findings. Possible to diagnose. If treatment, I'll just give you a brief lining of treatment and complications. If I take care of this, that's more than enough for most of the diseases going forward, fine? So when I look at the pathogenesis, there are a few things which are important for me. One, definitely atherosclerosis. I'm not going to repeat how atherosclerosis causes aneurysm. We know that more and more intima, it goes and gives pressure in the media, it destroys the media. Definitely the wall becomes weaker and causes, right? There's one type of thing called as an inflammatory aortic aneurysm or inflammatory abdomen aortic aneurysm, right? AA is for abdomen aortic aneurysm. Do you know any vasculitis? Have you come across any vasculitis in your life? Any named vasculitis? Whatever comes to your mind. Giant cell arteritis, you must have heard about them for sure, right? Possible, right? So inflammatory aneurysm can be secondary to vasculitis. There are few vasculitis which we'll be discussing very soon, called as a large vessel vasculitis, right? When I have a large vessel vasculitis, obviously a large vessel vasculitis can destroy the vessel wall. When I have a vasculitis causing destruction of the vessel wall, it will heal. Am I right in saying that healing tissue is never as good as a normal tissue? Is that statement right? Maximum strength is 70%. So vasculitis or inflammation to the aorta, whatever may be the cause, will weaken the aorta, and definitely there's a possibility it can cause an aneurysm, right? Third type is a subgroup of disease called as an IgG4 mediated disorder. Okay, so IgG4 mediated disorder, it's a kind of a relatively new disease which is in existence for the past 5-6 years. That's all. So IgG4 mediated disorder, what happens is there are few chronic disorder. I am subclassifying and saying that IgG plasma cells are the reason for this. I have here also IgG secrete or IgG4 secreting plasma cells. These plasma cells are going to cause destruction of the vessel wall, destroys the vessel wall. When it destroys the wall of the aorta, automatically it can cause aneurysm because it weakens the wall of aorta. The reason why this subclassification is required is, have you heard or come across the drug named rituximab? Have you heard about rituximab? Some of you must have definitely heard about the term rituximab, right? Rituximab is antibodies to which drug? Which thing? Have you heard about this? It's antibody to which one? Antibody to which one? Cancer treatment, right? Antibody to what? This is antibody to CD20, right? It's antibody to CD20. When you come to pharmacology, we'll learn, and also we'll come to lymphoma, we'll learn about that, right? It's anti-CD20. CD20 is in every B lymphocyte. So when I give rituximab, B lymphocytes will be dead. If B lymphocytes are being killed, do you think plasma cell will ever form? If B cells are not there, plasma cells are not formed, right? So this treatment is slightly varied. I know this plasma cell is a problem in this patient, so I particularly treat with rituximab so that destruction will reduce and obviously the risk of aneurysm and rupture will reduce, right? That's why I need to keep it separate, right? The next, I have one more cause of abdominal aortic aneurysm, which is mycotic aneurysm. What comes to your mind when you hear the term mycotic aneurysm? This one, secreting plasma cells, not secondary. I didn't write secondary anywhere. Okay, it's IgG4 secreting plasma cells, right? Okay, what is the term? What comes to your mind when you think of mycotic? Okay, secondary to vasculitis. Sorry, secondary to vasculitis, right? Fungus, right? So, right in big terms, this is not fungal related, because there are few things where my terms can be misleading. Because at the end of the years, like after 4-5.5 years, you will remember only name. You will automatically name the disease. You will automatically think, okay, this is the name of the disease, so this should be the disease, right? So this is not fungal related, it's bacterial related. It's definitely a complication of infection, but bacterial is more common than fungal here, right? This is secondary to bacterial infection of the vessel wall. The most common bacteria seen here is Staph aureus. Again, you need not remember this. I'll give you a classical scenario that can help you easily understand this. And the most common artery involved is femoral artery. How many of you have seen blood collection or in your hospital or wards? When you go to your clinics, have you seen your seniors collecting blood or the staff nurse collecting blood? You must have seen, right? At least some part of them you must have seen, right? So if you look at the blood collection, generally what is said is, when you have to collect blood, first you have to wipe the place with betadine, antiseptic. Then you have to wipe the place with alcohol, because alcohol clears betadine. Third, you have to wipe the place with saline. Then allow it to dry, so the entire place has no organisms. Then you prick the individual. So there is no commensal in the skin goes inside, because one of the important commensals of skin is Staph aureus. Every person's hand has Staph aureus. So if I don't clean this area and I inject, am I right to say that there's possibility Staph aureus can go inside the vessel? It can, right? When Staph aureus enters my bloodstream or blood vessel, is it pathogenic or commensal? Staph aureus is one of the worst things, right? I'm sure Dr. Mamta, if she has covered cardiovascular system in your microbiology, you must have heard about infective endocarditis, where Staph aureus is one of the important cause of infective endocarditis, right? So Staph aureus can enter. So this, the entire reason of mycotic aneurysm in femoral arteries, doctors. If you don't clean the area properly and you inject an injection, there's a possibility that the commensal organism in the skin can enter into the circulation, which can cause a problem, right? So if you and me and every doctor in the future determines I should clean properly, or the staff nurse thinks I should clean properly, then take a blood, this disease can be eliminated, right? That's one cause. There's one more cause of, this is the most common cause, the staph aureus, and there's one more cause of abdomen aortic or mycotic aneurysm, which is infective endocarditis. We'll read about infective endocarditis when we come to CVS. So just for a superficial understanding, the cardiac valve is having infection, right? If the valve has infection and the heart keeps on beating very fast, is there a possibility that the infection can break from the valve and cause an embolus? Possible? Definitely possible, right? And that embolus goes and lodges in a vessel, it destroys the vessel, causes aneurysm, right? So these are the four possibilities of how an abdomen aorta can have aneurysm: atherosclerosis, inflammatory, your IgG4 mediated, and also you have mycotic aneurysm, right? So whatever may be the etiology, clinical examination, you have an abdomen mass. Okay, an abdomen mass. Can you palpate your abdomen now? Just put your abdomen, a hand on your abdomen, and just feel it for some time. When you feel your abdomen, automatically for most of you, especially if you're thin, abdomen will be pulsatile. Just normal. Put your hand on your tummy, that's all. Just need not press. Keep your hand on your tummy. You can feel the pulse. When you go and read your surgical textbooks, it will be written that when you have a pulsatile abdomen mass, think of an abdomen aortic aneurysm. Why I told you to palpate your normal abdomen is the best time of palpation is when you lie down, because when you sit, all the rectus, transverse abdominis, everything will become taut and you will not be able to easily palpate it, right? When you lie down and palpate, pulsatility can be felt because aorta is pulsatil and I can feel aortic pulsation. So here, when I write or when any textbook tries pulsatile abdomen mass, which means most of the time these are visible pulsations. Don't mistake palpable aorta as an abdomen aortic aneurysm. Aorta will be palpable, that's all. When my carotid is palpable, aorta also will be palpable, especially when the person is very thin. When you have a big mass which can pulse, when you look at it, it can be pulsatile. Definitely abdomen aortic aneurysm, right? So when you have an abdomen aortic aneurysm, whatever may be the cause, look for an investigation. You need to do a radiological investigation. So in radiological investigation, whatever may be the investigation, be in a CT scan or a Doppler, whatever it is, if the size is more than 5 centimeter, it's dangerous. If the aneurysmal sac is more than 5 centimeter, it's dangerous and there's a possibility of rupture. So if anything is more than 5, there are few textbook in surgery which say 5.5 centimeter. I will leave to the surgeons. Generally, anything more than 5 centimeter or more than equal to 5 centimeter, it has to be managed very, very carefully. Has to be immediately given a surgical intervention. Don't wait and watch. Immediately do one surgery, right? So this is what happens when there's a problem. Obviously, you take for a treatment. Treatment is surgical. Yeah, something cousin. I'll come to it. Just give me a second. We have something cousin. Background graft. It's a graft. So what we do for this aortic aneurysm is, it's already a pulsatile area, right? It's like this. So what we do is we put a graft which compresses this area and it stays like that, right? So the graft, this is what the diagram graft is. It just compresses the aortic aneurysm area so that it doesn't rupture, right? When you go to your surgical things, Sandeep will definitely talk on how to put an background graft and everything about, right? Okay, usually, Sajad, coming back to your question, the location of abdomen aortic aneurysm is between your renal artery and the bifurcation of aorta. Let's say between a renal artery and your aorta's bifurcation. Bifurcation means the common iliacs, right? This is the common site of abdomen aortic aneurysm between the renal artery and aortic bifurcation. Fine. Okay. So I know about how to treat, how to manage, and how to know the etiology. You have to also know the complication. If you know about a disease, I am 100% sure you can tell me the complications. Tell me whatever comes to your mind. You have a 5 centimeter bulge in the aorta. What all could be the outcome or complication. Whatever comes to your mind. Anything which comes to your mind, you can tell. You will be right most of the time. I'll tell Vidhi. I'll come to your question very soon. Can it rupture? It obviously can be rupture, right? It can rupture. Most of the ruptures are fatal, right? Perfect. Dysphagia, if it's in thoracic aorta, yes, I can have dysphagia because it can compress my esophagus and everything. Abdomen aorta generally doesn't cause dysphagia, right? Danish Mohammed has told about turbulent flow. We'll take whatever Danish said. If there's a turbulence in the blood flow, what is the possibility? We read about something called as a virtuous triad. If a blood flow becomes turbulent, what's the next step? Because of the turbulent blood flow, can I have a clot formation? It can cause a clot. Obviously, it can cause a clot, right? Perfect. So, because of the turbulent flow, it can definitely form a clot or a thrombus. And it's an aorta, it's a sac. I'm having a thrombus in the sac. Is there a possibility the thrombus can break and become an embolus? It can undergo an embolism, right? So, thromboembolism is an outcome. Perfect. Any more outcomes? Any more outcome? It's an abdomen aortic aneurysm. Your abdomen aorta has become 5 centimeter bigger, a sac. Can it compress ureter or can it rub the vertebra? It can, because it's bulging, right? I don't have enough space in my abdomen, it bulges, right? So impingement symptoms are possible. So it impinges on vital structures. It can impinge on the ureter, causing an obstruction, can cause hydronephrosis. It can impinge and it can also erode your vertebra, which also is possible, right? Again, it's compressing. Impingement is just compression of the adjacent structures surrounding the aorta. Like what Vidhi said, if it's the thoracic aorta or the arch of aorta, I can have obstruction of the esophagus, compression of the esophagus, dysphagia can happen, fine? Okay, that's also possible. There are few outcomes of an abdomen aortic aneurysm, right? Vidhi, the difference between vasculitis and atherosclerosis. Vasculitis is pure inflammation of the vessel wall entirely. All the layers of the vessel can be affected in vasculitis. When I say atherosclerosis, it's chronic inflammation involving tunica media, which has a particular risk factors. Vasculitis is, we'll read vasculitis, we know the different pathogenesis is different. Outcome might be the same, but pathogenesis here is different. In atherosclerosis is due to hypertension, hyperlipidemia, your blood sugar, cholesterol, age, all of them are risk factors. We know a little bit about abdomen aortic aneurysm, right? We know the etiology, clinical symptom, your maybe the pathogenous part, maybe your treatment part, and also we know about the outcome of abdomen aortic aneurysm, right? Sajad, the fistula formation is a bit unlikely, right? If can cause fistula, if you feel aorta is going to cause fistula, will the patient survive? Might not, right? There will be huge amount of blood from the aorta going into different organ. The patient might not even survive. So I can call it a rupture. That's all, right? Okay. You know a little bit about abdomen aortic aneurysm. Right? The next thing what you're going to see is about aortic dissection. Entire first year in anatomy, you did dissection, right? What does a dissection mean? What does dissection mean? You have done the dissection in the entire first year of anatomy. Tell me what is dissection? Dissection is not to cut, right? So we completed an entire anatomy, but we need to know the exact definition or exact meaning of dissection. Dissection means to separate. That's what dissection means, right? Cut is, you know what is a cut? Cut is an incision, right? You incise and you dissect. That's what dissection means. I have to separate different layers. That's what is called as a dissection. In anatomy we use it, and surgical also we use dissection. Different planes of dissection, right? So aortic dissection means something is going to separate the aorta. What do you think can tear the aorta? Only one person which can tear the aorta is blood, because the lumen has blood, that's all, right? So aortic dissection is when the blood separates, it's going to separate the layers of aorta. Okay, the blood separates the layers of aorta, we call it an aortic dissection. That's all. To be specific, The blood separates the layers of tunica media of the aorta and it travels between the tunica media of the aorta. It's called as an aortic dissection. Okay, and travels in the layers. That's called as an aortic dissection. So if it's going to separate the tunica media, the wall of the aorta should be weak or strong. Undoubtedly it should be very weak, right? If the wall is strong, there's no possibility blood can go and separate it. The wall should be weak. Only then the blood can easily separate the walls of aorta, right? It will be weak aorta. So this is an image from Robbins. Tell me what stain is this? If you have listened to yesterday's lecture and if you have read it, I'm sure you will tell me what stain it is. What stain is this? This VVG, perfect, right? That's a perfect VVG. So it's a Berhoff Van Giesen stain. Okay, great. Silver stain, VVG stain. Von Kosa stain for calcium is a normal VVG stain, right? I'm just zooming up this. If this is VVG stain, what are these fibers? These are elastic fibers. If you remember yesterday, I gave you an image of your smooth muscle artery on a VVG where we saw some random fibers. But look at this, an elastic artery, the entire tunica media will be full of elastic fibers. That's how an elastic artery looks in tunica media, right? I'll just zoom out here. Can you look at this area? This area, what you're seeing here, that's your blood. And also here also you can see little bit amount of blood here, right? So you see blood, this also is tunica media. This also is tunica media because it's an elastic artery. Aorta is an elastic artery. You see blood between the layers of aorta, you call it aortic dissection. That's the simplest definition of aortic dissection, right? So blood is separating and traveling between the layers of aorta. I call it aortic dissection. In other words, aorta is being torn. If aorta is torn, I'm going to have dissection here. Let's look at the pathogenesis. For an aorta to be torn, the aorta should be extremely weak, which means there is something which is destroying aorta. There are two things for pathogenesis, but my outcome is common: destruction of aorta, right? A patient who is hypertensive, that's one thing. And then I have patients who have Marfan syndrome. What's a mutation in Marfan syndrome? We did read about mutation in Marfan syndrome. They have a mutation called as fibrillin gene, right? Okay, if mutation causes in fibrillin gene, that's going to be the problem in Marfan syndrome. Because of the fibrillin gene mutation, there's going to be an increased activity of TGF beta. Okay, in hypertensive patients, again on a long-standing hypertension, there's going to be more amount of angiotensin's activity. So this TGF beta binds to the TGF beta receptor. Unfortunately, angiotensin also binds to the TGF beta receptor for the simple reason the receptor of angiotensin and TGF beta is more or less similar appearing morphologically or structurally, right? So both of them binds to TGF beta receptor, right? Similarity of angiotensin receptor and TGF beta receptor, both of them binds, right? Once TGF beta receptor binds to it, maybe angiotensin or TGF beta, it gets activated. This activation destroys elastic fibers. Okay, this destroys elastic fibers completely, right? So once an elastic fiber is destroyed, let's assume this may normal aorta. I think I told you this when we were discussing Marfan syndrome also. The normal aorta's tunica media will be like this. We just now saw, right? It's parallelly oriented, right? Because of the destruction of the elastic fibers, it becomes like this, broken. It's just broken, that's all. Because of this break, the aortic media becomes very weak. It's a broken elastic fiber or a broken tunica media of the aorta, right? So we have to name this. You guys are going to name this, right? Here my elastic fibers are broken. I'll just zoom this area alone, right? I'll just zoom this area. Let's draw this broken area. Let's complete it. It looks something like this. If you have a round structure like this in your ovary or in your hand, what do you call them? Tiny round areas in an ovary, what is the name given? Or in kidney or in liver, any organ, tiny round areas, what do you call them? Can I use the term cyst? Can I call them cyst? I can call them cyst, right? So I'm having cyst-like areas of destruction of tunica media, because elastic fibers are seen in tunica media, right? PCOD or PCOS, it's a cystic disease, right? So here, destruction of tunica media of the aorta, which is made of elastic fibers. So the name is as simple as that. So the microscopic appearance of the aortic dissection is cystic medial degeneration. It's very simple, right? Be it hypertension or Marfan syndrome, ultimate microscopy is cyst-like areas of degeneration or necrosis of the tunica media of aorta, which makes the aorta very, very weak. So that's the reason it can have an aneurysm or it can have a dissection, right? Now, I'll just go back in the pathogenesis. I just want you to think, because the thought process is, thinking capacity is the only thing which stays with you forever. Marks don't stay with you forever, right? Now I told the pathogens of fibrillin gene, Marfan syndrome is TGF beta, binds here, destroys. Hypertension, angiotensin binds here, destroys. If you are the scientist who knew how to manage this, how will you manage? You want to block the destruction. What's the best way to block the destruction? Think in terms of a doctor, think in terms of a scientist. I want to block the destruction in this patient. How do you block the destruction? How do you block the destruction? Block TGF beta or TGF beta receptor? Perfect, receptor inhibitor, right? That's what. That's enough, right? See, you start thinking, exams become very simple, right? Now I told you just now, because of the structural similarity, angiotensin binds to TGF beta receptor. So am I right in saying that structurally they are same? So can an angiotensin receptor blocker block TGF beta receptor? Can the reverse be true? Because both of them structurally same. So can a blocker of angiotensin receptor also block TGF beta receptor? It can block, right? So here, treatment for me to prevent aortic dissection in Marfan syndrome or to prevent aortic dissection in hypertension is your ARBs. You must have read about ARBs for sure, or you will read in future in pharmacology, angiotensin receptor blockers, which means it's not a common complication of hypertension, because most of the hypertensive patients have ARBs or AC inhibitors, so angiotensin level is kept to the minimum. But if you have a patient who is an uncontrolled hypertensive, not taking the drug properly, or the amount of angiotensin production is more than what the patient is taking drug for, is there a possibility of the destruction to happen? It can happen, right? So it's an unusual outcome of hypertension, not an usual outcome. But Marfan's, this is the segment. For Marfan's also, the treatment is same ARBs. Losartan, candesartan, all these sartans are your ARBs that can block the entire pathogenesis, right? You know a simple physiology, you block something, you know the pathology. You activate it or block it again, you know the treatment as well, right? You just need to know normal. If you know normal, rest everything is a piece of cake for us, right? Now let's come back. I know a little bit about aortic dissection. Now we know about the pathogenesis. Now etiology is two things: hypertension and Marfan's. What is more common? I'm not going to say most common. You will definitely, any day you're going to say most common. Most common is undoubtedly hypertension, right? Marfan syndrome cannot even come near hypertension in terms of incidence and prevalence, right? Marfan syndrome can cause, but hypertension is definitely your most common cause, right? Next question. Okay. Siddharth, it's not about ARBs from what age group. When the you have few criterias based on the texture change or based on the aortic involvement, you start giving. If there's tiny change, you start giving. But these days, generally at diagnosis, they start giving ARBs because Marfan syndrome is an autosomal dominant disorder. Generally, it is diagnosed on a later age group because every dominant disorder presents later in life only. Fine. Okay. Coming back to this, which of these two do you think will present at an younger age? When I say younger age, 2030s. which will present at 2030? Marfan's will obviously present at a younger age group, right? Okay, when I say younger age, around 20s, 30s age group. Hypertension will be presenting easily above 40 or 50 years, 40 years to 60 years, right? It will definitely be an old age group, right? Why I told you this is, when you're going to write a next exam, the only thing I want, everyone knows this. Every person will know it. Every MBBS doctor will know it as well. But when I say aortic dissection, by default, what comes to your mind is hypertension. So if I want to make you fall there, I change the age group. Same clinical history, same examination finding. I put age of 20-year-old, 6.2 feet tall. Very subtle finding. Marfan syndrome patients will be tall. 20-year-old age group, aortic dissection, you think of Marfan's. 50, 60-year-old, Marfan's is not going to wait till that time. Think of hypertension, right? So age, gender, few clinical examination findings are very, very important to tell what is the most likely cause, right? So we know this is the most likely cause. I need no clinical features, right? But there are two things here. The dissection, wherever it happens, it presents in that area. So as a thoracic aorta having dissection, you'll have pain in the chest area. If abdomen aorta is having dissected or being torn, you'll have pain in the abdomen, right? So you'll have an acute chest pain or an acute abdomen pain. You'll have extremely acute abdomen pain or an acute chest pain. Whatever may be the area, whatever may be the location, there's a very unique finding of aortic dissection. Both the pain will radiate to the back. That's very, very important. Be it chest pain or abdomen pain, and the question will definitely say it radiates to back. Okay. Do you know any other disease which can have acute abdomen pain radiating to the back? Anything which comes to your mind? Acute abdomen pain radiating to the back? Comes to your mind? You must have, right? Pancreatitis. That also is a very classical clinical manifestation like an abdomen aortic dissection. Pancreatitis is one of the important cause, extremely acute abdomen pain which can radiate to the back, right? Okay. Now I want you to differentiate an acute pancreatitis from an aortic dissection. How will you differentiate? You are the intern sitting there. The patient comes to you and says, "Sir, extremes of pain radiating to the back, going to the back." You need to differentiate pancreatitis versus aortic dissection. I don't want investigations. I want clinical examination based differential diagnosis. Because any investigation you do is going to take 2-3 hours to come. BP, that's more important, right? Look at the vital signs. Vital signs are very, very important. If the patient is having aortic dissection, the patient will be hemodynamically unstable because the aorta has been torn and the blood is traveling between the layers of aorta. So definitely the patient becomes hemodynamically unstable, extremes of instability, kind of in a shock. Pancreatitis, there's no problem in the blood circulation. Vital signs will be maintained. If the patient is hemodynamically unstable, think of aortic dissection, immediately send to cardiothoracic surgeon. Because even with treatment, dissection has 50% mortality, even with treatment, right? So without treatment, it's very, very difficult to handle a patient with aortic dissection. With treatment, definitely there's a risk of losing the patient as well, right? So another clinical feature, you know, the pathogenesis. Before treatment, I want to little bit learn about the classification. Okay, there are two things in classification. One was called as DBK's classification. Both of them are mentioned in Robbins. DBK did a complete anatomical classification. Okay, he did completely on anatomy. The second classification is called as Stanford classification. Stanford just stole DBK classification. The university made it prognostic. That's the only important thing, right? The history tells us multiple things. If you stay with anatomical classification or anything in basic science, when you're not involving patient into the system, you will be outdated, you will be replaced. DBK is an amazing surgeon. He did autopsies for 10, 11 years continuously and came up with a classification. But he didn't consider patient. Stanford took the same data, put into patients and it's been completely changed, right? There's an image from Robbins, the same image whatever is there in your Robbins textbook. You on the top you can see DPK 1, 2, 3. In the bottom you can see type A and type B. Type A and type B stand for DPK 1, 2, 3 is your anatomical classification of DPK, right? If I'll just zoom this here, you can see a tear here. The intima should tear, and if you can see, this is the adventitia, this is your intima. So between the adventitia and intima, I have red color, which is blood dissecting through the media, right? There are three types of DPK classification. DPK 1, the tear happens from the root of aorta. It happens till your aortic bifurcation, from the root of aorta till it, throughout. Second is from the root of aorta till the origin of first vessel, the innominate artery origin, it tears, right? That's your DPK type 2. Both type 1 and type 2 are being called as Stanford type A, right? This is your Stanford classification, right? Stanford type A. DPK type 3 is the dissection starts beyond your subclavian artery. Okay? Beyond the origin of subclavian artery, the dissection starts, and it also can go till the bifurcation of aorta. I have three different types of classification, and this is type B. Now look at both of them and tell me which of these two, type A or type B, which will have a poor prognosis and why. I want both the answers, which will have poor prognosis and also why they'll have a poor prognosis. Why will they have a poor prognosis? First, which? So you can say A or B. You have still 50% of getting the right answer. A will have a poor prognosis. Why? A is right. A has a poor prognosis. B has a better prognosis. But why A has a poor prognosis? Type A will have a poor prognosis for sure, right? More than hard to locate a Danish. I'll just zoom this here. No, it's not about the both sides. Can this dissection go into the cardiac tissue? Possible? Because it's root of aorta. Below that I have heart. So this can tear and extend to the heart. That's one problem. And my head and neck vessels are involved. If my head and neck vessels are involved, my primary vessels are involved, there's more possibility it can become more dangerous. On the other hand, here, my head and neck vessels are not involved. It's uninvolved, and root of aorta is free. It cannot go into the heart tissue, right? Because of the possibility of root involvement and the major vessel involvement, type A has a poor prognosis, and because the root is not involved here and the major head and neck vessels are not involved here, okay, major vessels and root both are not involved here, because of this they have slightly a better prognosis. When I say better, the mortality rate is around 30 to 40%, more than 50 if it's worse. Any day it's going to die. The patients, even with treatment, very difficult to take care of the patient because aorta is getting torn, right? I'll leave it to Dr. Sandeep to talk about how to treat aortic dissection. It's not my forte, but it requires an immediate surgical management, right? So we know about the pathogenesis. We know a little bit about the medical management for Marfan's as well. We also know how the patient will present. We know the classification. Microscopy we already saw. This is what's going to happen. Same VVG stain, silver stain. You can see cyst-like areas of degeneration. That's what we call them as. There are multiple areas, right? Cyst-like areas of degeneration. We call them in cystic medial degeneration. That's a cystic medial degeneration of aorta. Fine. This is what happens. Whatever may be the etiology, be it hypertension or Marfan's, the aortic dissection will have cystic medial degeneration only. Fine. So what will be the effect of heart, right? So if it's a root of aorta is getting involved, when the myocardium undergoes tear, the cardiac function also will be affected, right? The cardiac output will be affected because myocardial is involving and myocardium is undergoing tear, right? So it will not pump properly. So along with this tear, I will also have more of hemodynamical instability. So there's more chance of losing the patient. That's what it is. I hope HR is heart. Fine. Okay, so we know about dissection as well, right? Vasculitis, like I said, it's not a major component of your CBME curriculum. I don't know why CBME curriculum want to ignore vasculitis. Fine. If they ignored something, we'll definitely read it. for more from an exam point of view and just to apply our concepts of your acute and chronic inflammation, right? So vasculitis is generally divided into based on the size, large, medium, and small vessel vasculitis, right? You have large vessel vasculitis, medium vessel vasculitis, and you have small vessel vasculitis. Okay? See, memory is a very, very important commodity for you, right? Don't waste memory. Remember things, memorize things only when you have no other option. Logical statement, don't waste memory. Because memory is tiny structure is there which is going to help the memory. I cannot remember everything, right? Any classification you read going forward, I don't want you to read all the three things. Read two of them, which is easy to remember. Large vessel vasculitis, I have two guys. Giant cell arteritis is large vessel vasculitis or temporal arteritis. Other is Takayasu arteritis, which is large vessel vasculitis, right? Medium vessel vasculitis, again I have two guys. PAN stands for polyarteritis nodosa. That's expansion for PAN, polyarteritis nodosa. And also we have Kawasaki disease. Okay? The PAN and Kawasaki disease. So these are two statements. Easy to remember. Rest everything is small vessel vasculitis. Okay? But when you read like this, please don't forget large and medium. If you forget large and medium, everything goes for a toss. Use this for pharmacology classification. There are three groups. Read two groups which have less number of drugs. If it's not there in these two, it will be in the third only. You can handle Viva easily. Why I'm leaving the three is, you will anyway read the disease. So you can fill it up. Definitely you can fill it up. It's not a concern at all, right? Memory is very, very difficult. Use this. When you go to surgery, you will read about TNM classification. It's very difficult to remember TNM classification. N and M, ignore. No one wants to remember. T stage, they will ask in surgery, Viva or postings or even in exams, right? Remember T2. Just remember T2. Less than that T1, more than that T3. If it goes to the adjacent structures, T4. You need to know how to remember things. If you know that, you excel medicine, because logic you don't want to remember, it automatically will come to you. But memory is something which is very difficult. If you're blessed with an amazing memory, great. But if you feel that you're forgetting things, use these maybe cheat codes to escape it. Fine. Which one? The vasculitis. Okay, so rest everything will come into small vessel vasculitis. We'll read rest of them and then we'll definitely fill this up. Now, for now, it's rest vasculitis, right? TNM is a horrible thing, right? So TNM is difficult to remember, but that's the only way to go ahead, right? So now I'll go to giant cell arteritis. Like I said, the other name for giant cell arteritis is temporal arteritis. Okay, that's the other name for giant cell arteritis. I'm going to tell you only two things. Rest everything you will tell me, right from the pathogenesis to clinical features to microscopy to treatment. Everything you will tell, because we have a very good basic foundation of general pathology and we have an amazing brain. Brain will help us to extrapolate every little bit of thing required for me here, right? The only thing I'm going to say, the most seen artery or most affected artery, let's say, or the example for me is temporal artery. We have studied everything with the help of temporal artery. So that's the most visible artery, let's assume. Fine. Next, it's going to have the pathogenesis of temporal arteritis is chronic inflammation. There's only two things which I want you to know. If you know these two, that's more than enough for us, right? What's the hallmark of chronic inflammation? You guys know that. What's the hallmark of chronic inflammation? Tissue destruction, healing by fibrosis, right? That's all. It's the same TDHF, tissue destruction, healing by fibrosis, right? Now let's try to extrapolate things, right? Put your pens down. I want you to just think and comment whenever I ask something. That's all, fine? So here, my temporal artery is going to have tissue destruction and healing by fibrosis. What do you think will happen to the lumen of superficial temporal artery? When I say temporal artery, it's a superficial temporal artery, right? What do you think will happen to the superficial temporal artery? What will happen to the lumen? The lumen will become smaller, right? So if superficial temporal artery comes here, you know the anatomy obviously, right? Superficial temporal artery comes here. So the lumen of the artery which supplies the temple region is going to become smaller. Will there be ischemia of this place? Yes. If there's an ischemia of this area, an ischemia, definitely it will cause pain, right? The patient is going to have pain here. So how will the patient, what will be the patient presenting symptom? Temporal region headache. That's all. Patients present with headache, just temporal region headache, right? So I'm sure you must have had headaches for sure in your life, right? When you had headaches in your life, have you ever touched this area? Can you feel the pulse here? Sometimes normally also you can feel the pulse, especially when your head is aching, your superficial temporal artery will be very much pulsatile, right? How many of you have observed that? Or next time when you have a headache, just touch here, you can feel the pulse, right? So here, it's not feeling the pulse. Any question which says temporal headache with a palpable artery, that's a very important statement. Because this is a fibrotic artery, I can palpate a fibrotic artery. You can never palpate any artery. You can feel the pulse. Feeling the pulse is different from palpation. For us to remember and to easily correlate, if the temporal artery is like a rubber band, right? It's thick like a rubber band, then I call it, okay, it's a palpable artery, right? So if it's a palpable artery, I want you to think of giant cell arteritis. When you had a headache, it will not be palpable, it will be pulsatile. You have pulsations, right? That's where your science comes into play. The medicine is not read from textbooks, it's read from outside, it's read from the practical experience. If it's pulsatile, the blood flow is more, that's what is causing headache. The simplest treatment is vasoconstriction. That's why caffeine works, coffee works, tea works. Because coffee and tea have chemicals which are vasoconstrictor, constricts this and takes care of the headache, right? That's the simplest reason why coffee works in a headache, fine? We read from the surroundings, not from textbooks, right? Let's extrapolate this. The presentation is temporal headache with palpable artery like a rubber band. It's an inflammatory disease. Can it spread? Or it will be just restricted here? Can it go to different parts of the body? It can and it will spread for sure, right? So when it spreads from superficial temporal artery, let's assume it went to my maxillary artery. What does maxillary artery supply? Which area or which muscle do they supply? They supply muscles of mastication, right? Definitely they supply your muscles of mastication, right? So if my maxillary artery supplies my muscles of mastication, next question for me here is, it's again going to have stenosis, it's again going to have tissue destruction, healing by fibrosis. That's what happens in my maxillary artery. I'll come to it, Chat. Give me a second, right? It has that, right? So I'm going to have tissue destruction, healing by fibrosis of my maxillary artery. It becomes smaller, it becomes stenotic. So when I talk too much, will there be pain? I'm staying normally, no movement, normal, less blood supply, okay. When I move it a lot, when I chew food a lot, I move with my jaws a lot, I'm not having enough blood supply for the moment, I have pain. Pain on movement is called as claudication. But when you stop the movement, pain will stop. The term claudication is very important. In surgery, you will read about leg claudication. This is called as jaw claudication. You move the jaw frequently, it pains because I'm not having enough blood supply. It's a very specific symptom. There are only two common diseases which can cause jaw claudication. One is temporal arteritis. The second is temporomandibular joint problem. I move, it pains, so joint might be a problem, right? That's my second symptom. Again, it's inflammatory disease. Can it spread further to ophthalmic artery? It can. If it spreads to ophthalmic artery, how do you differentiate? Sorry, what will be the symptom? Goes to ophthalmic artery, what will be the symptom? Can the patient have blindness? Possible, right? Definitely the patient can have a blindness, right? So blindness here will be, what do you think the blindness is? Reversible, irreversible? Reversible, irreversible. It's an ischemia of the retina, ischemia of CNS. Do you think ischemia of neurons of the retina is reversible? Reversible, irreversible? Irreversible, right? Just wait for some time, you'll know the answer, right? It's retina gone, it's not going to come back, it is irreversible. So I, with this information, we extrapolated my symptom. It's a chronic inflammation which is going to cause tissue destruction, healing by fibrosis. I'm just going to write whatever we discussed here, right? I'm just going to write whatever we discussed. We have to know the symptoms. The most important or the common symptom is temporal headache or temporal region headache. Okay, I'll have a temporal region headache, and the most important thing for me here is palpable artery. No artery will be palpable. This artery is becoming palpable because of the fibrosis, right? So this definitely can spread. Once it spreads, it can go to the jaw area, it can go to the maxillary artery. When my maxillary artery is involved, I'll have a symptom. This is called as an jaw claudication. Like I said, this is a very, very specific symptom, right? Jaw claudication is very specific. This has come in an MCQ previously. You have to remember it. I'll tell you the reason for this remembering. Because if I say headache, I have like entire book full of causes. Jaw claudication, 2 causes. One is TMJ joint problem. You press here, tender, painful, then I know it's TMJ joint problem. Or I have few tests to know it's a TMJ joint problem. It's not that, it's temporal arteritis, right? I need to know this because it can spread further. Once it goes to the next place, it goes to my ophthalmic artery. If it goes to the ophthalmic artery, it can cause blindness, and like you guys said, it's an irreversible phenomenon. It's an ischemia related blindness. So let's assume you have a patient presenting with jaw claudication. What's the next step? Diagnosis or treatment? Because I have an impending complication of an irreversible vision loss. What do you think will be the next step here? Diagnosis or treatment? Confirming the diagnosis like a biopsy or a treatment? You have to go with the treatment, right? I'm not going to wait for biopsy. Biopsy results take like 6-7 days. I'm not going to wait for that, right? I will go directly to treatment, and you guys are going to tell me the treatment. I told here it's a chronic inflammatory problem. My only goal here is to stop the inflammation. What's the best anti-inflammatory comes to your mind? What's the best anti-inflammatory comes to your mind? Steroids. Start steroids. When you suspect temporal arteritis in any individual in future, start steroids. Then do the confirmatory workup. Then do the lab investigation. Don't wait for the lab or radiology report to come. Start steroids. Then we'll see what happens. If it is not temporal arteritis, slowly taper steroids and stop it. That's fine. But I cannot take a risk of playing with the patient's vision, right? So these are my symptoms here. Let's put that into here. We already know symptom. Age group is generally more than 60 years. Let's assume more than 50 years. It's more commonly seen in women. Robbins as well as Harrison gives few non-specific symptoms. They'll say there'll be myalgia, there'll be tiredness. Myalgia and tiredness is non-specific, right? Fatigue. Attending college also causes myalgia and tiredness, right? Taking a class also or listening to this class also causes myalgia and tiredness. It's a very non-specific symptom. Anytime there's inflammation, body will pain, tiredness is bound to happen, right? It's a very non-specific symptom. Just to add your line of the questions, from 2 line to 6 line, this will happen, right? Let's say on a lab investigation, okay, I'll just write few tests. You are going to tell me what happens to the test. The values will be elevated, reduced or normal, right? 2 things for me here. ESR for your HODs, CRP for the younger generation. What will happen here? ESR and CRP in case of any inflammation. We already know inflammation, right? See, once we know inflammation, we can document every single inflammatory disorder. It's going to be elevated for sure, right? Because both of them are acute phase proteins, acute phase reactants will definitely be elevated, increased or elevated, that's all, right? Then I'll come to your biopsy. So biopsy, I need a minimum length of biopsy is 1 to 1.5 centimeter. I need minimum of 1 to 1.5 centimeter, right? Then a biopsy, let's assume it came to microscopy. It's a chronic inflammation. So what will you see in the microscopy of a biopsy? You know about chronic inflammation. What do you see the microscopy? I am 100% sure you know that. TB was chronic inflammation. What was there in the biopsy? Granulomas. Here also I see the same thing. I'll see granulomas. Don't think too much. Think very simple. When you want to think too much, no, you complicate things and you forget it, right? Granulomas. With the lymphocytes are inflammatory cells, especially for a viral disorder. Here I will see macrophage and granuloma. If you are not understanding that, look at the name, giant cell arteritis. Giant cell is nothing but union of activated macrophages, right? You will see granuloma and you will see giant cells. I need to prove that it is chronic inflammation. I need to prove that tissue is being destroyed here. What's the strongest layer in a blood vessel? Intima, internal elastic lamina, media, or adventitia? Internal elastic lamina, right? So if I say that internal elastic lamina is broken, can I say tissue destruction is definitely happening? Yes, right? So for me to prove, your Robbins will say there's a pathognomonic finding. Whenever I use the term pathognomonic, it's like sure shot. It's 100% present there, right? Pathognomonic finding is broken internal elastic lamina. For me to identify broken internal elastic lamina, right? What stain do you require? I need to identify internal elastic lamina. I need to say that's been broken. What stain is required? You know the answer. You need VVG stain, Verhoeven-Giessen stain, right? Perfect. Because it's elastic tissue, I need a VVG stain. Everything is sorted. Just for complication, treatment is with steroids. I will leave the treatment part to Santosh Patil. Let's see, medicine person will definitely be telling the treatment. I will stop with diagnosis. That's my role, and I want you to make sure everything starts with only this guy. I know this, I extrapolated. We just extrapolated each and everything, be it my clinical examination or the approach or my microscopy, right? Let's go to this. What stain is this? It's obviously your PVG stain, right? In your Robbins, there'll be an old lady picture of this very tortuous vessel here, right? In a picture, no one can diagnose temporal arteritis. I need to palpate, only then I can diagnose temporal arteries, right? Okay, look at this. VVG, internal elastic lamina, definitely is being broken or being fragmented, right? That's a broken internal elastic lamina, definitely diagnostic of temporal arteritis, right? On the other hand, I'll go to the next question, next image. What are these? I want everyone here to name this cell. I'm sure 100% you will name this cell. What are these cells? One blue dot or multiple blue dots? You have multiple blue dots. Multiple blue dots stands for, they are giant cells, right? Perfect. So you can pick up a giant cell. It's nothing but more than one nuclei. Anything with more than one nuclei, I call it a giant cell. That's all, right? So that's simple about giant cell arteritis. Medicine and pathology is very simple. The person who complicates that is you guys, we guys, human beings intervening, right? Let's assume you have a question of some random history, random thing, and microscopy it will be written, biopsy of the temporal artery is given in the microscope. Happens. Your seniors, quite a few of them, look at the question, panic, and try to understand what's there in the biopsy. They cannot make a head or tail of it. And then they write some random answer and come. Every MCQ is very simple. What's the only disease you know in temporal vessel? Temporal arteritis, right? You don't know any disease in the temporal artery. You know only one disease. Then why there's a confusion? They have given you the history, they have given you the age, they have given you jaw claudication, they have given you an image, and they have told that temporal artery is involved. In spite of that, you're going to do a mistake. I'll come to the exam hall and hit you. Panic results in problems. You have a very stable mind in an exam, you can solve any question, right? So if you have access to DPPs, I want you guys to, after class, any class, have an amazing meal, take rest for some time, and solve DPPs very, very religiously. While solving DPPs, switch off your other WhatsApp and everything or other things. Don't get distracted. Every day, you solve 10 questions consistently for the next 1 year. Without even knowing the topic, you will know this is the right answer. That's experience. You can definitely solve a question. Next exam is not important at all. 100% you'll get a good mark. What's more important is after you finish your next exam, after you get your MBBS degree, you come outside, when you sit in front of the patient will not give you four choices, right? Patient will not say, sir, what is it, A, B, C, or D? That's where we are going to have a real tussle. We'll make sure you'll be prepared for that also during internship, right? So don't worry about an exam. Exam is any day easy. You will definitely do an exam, right? Let's go to the next vessel, Takayasu arthritis. That's also one large vessel vasculitis, right? Takayasu arthritis, the most common artery which is involved is subclavian artery. Okay, and the pathogenesis here, it's also chronic inflammation of the subclavian artery. What's the hallmark of chronic inflammation? Same, tissue destruction, healing by fibrosis, right? After maybe once you have done little bit of more systemic pathology, you will say this guy doesn't know anything apart from inflammation, autoimmunity, and neoplasia. You need not know anything. Believe me, tissue destruction, healing by fibrosis helps us to understand half of Robin's just one disease, chronic inflammation, right? We just need to excel that and put in different areas and make medicine wonderful, right? Now let's go. It's same tissue destruction, healing by fibrosis of the subclavian artery. What will happen to the lumen of subclavian artery? Bigger, smaller, same routine. It will become narrow. When the subclavian artery lumen becomes narrow, subclavian artery continues as what artery? Subclavian from here goes as axillary, axillary to brachial, radial and ulnar, right? So if the subclavian artery is going to become smaller, can I say the blood supply to the axillary artery will be reduced, brachial artery will be reduced, radial and ulnar artery will be reduced? Yes, for sure. So am I right in saying that the patient will present to you with the entire hand or arm having pain and fatigue because the blood supply to the entire arm is abnormal or reduced? The pain and fatigue on movement, generally tiredness like that. There's two diseases which will cause pain from here till here. One is Takayasu arthritis. The second disease is cervical spondylosis. Have you seen any of your patients, relatives having cervical spine problem? You must have definitely come across, right? Which is common? Takayasu arthritis is common or cervical spine problem is common? Not from textbook, tell from your experience. Cervical spondylosis is definitely much more common than Takayasu arthritis, right? Perfect. I need to differentiate them because if I don't differentiate them, I cannot treat them, I cannot diagnose them, right? Differentiation is very, very important here. How do you differentiate them? I leave it to you. Patient has come to you and told, sir, I'm having pain from here to here. Treat me. How do you treat? Or how do you differentiate a cervical spondylosis pain from a Takayasu arthritis? It's your patient. Patient is waiting for a diagnosis. I'll give you a clue. One is a vascular problem, one is a neurological problem. In which of these two diseases, the radial and ulnar pulse will become feeble or low volume? See, you cannot palpate a subclavian artery, that's a concern, right? Aslam, it might not cause necrosis of the finger because it's not infarct, it's just ischemia, reduced thing. But can I say, like I said, the volume of the pulse will be less, right? So when I have a chronic inflammation of the subclavian artery, what happens is it's a very simple thing. Same thing, reduced lumen of subclavian artery. Because of this, the patient presents with fatigue in the arm or pain in the arm, entire arm or pain in the entire arm, But for fatigue and pain, I have two differential diagnoses. One is my Takayasu, other is my cervical spondylosis. Both will present that, right? So on examination, it helps me. The peripheral pulses will be of low volume or an feeble peripheral pulse. A feeble peripheral pulse is diagnostic of an Takayasu arthritis. Fine. Okay, that's very important for me to say. Okay, it's a vascular related pain, right? The next question: have you palpated? Have you felt radial pulse? You must. You must have, right? You must have definitely palpated radial pulse. The first time you feel a pulse, no, you have the feel of a doctor, right? You are in second year, very young. I want you to do clinical examination as per the textbook, not told by your seniors. I'm not saying your seniors are bad, but I want you to have 100% right evidence, right? The next time onwards, when you're going to see any patient, when you're going to palpate a pulse, palpating a pulse in one hand is wrong. Every time, pulse should be felt bilaterally, because you don't know what is feeble pulse unless you compare. Every pulse should be felt bilaterally. Apical impulse should be felt bilaterally. Then yes, it's in the left side, I go for it, right? It's always bilateral. Not compress both sides, carotid on one side, right? The rest, every pulse in my body, even if it's dorsalis pedis, bilateral. I need to compare. Please do bilateral. When you palpate bilaterally, you know, okay, one is less volume, one is more volume. I know it's most likely occlusion somewhere, Takayasu arthritis, right? Obviously, when you have the symptom, there's an MCQ which came to this. Because of this, we call them as pulseless disease or pulseless syndrome. These names are made for us to remember, that's all. I'll come to that with you, right? These names are just for us to remember. The chance of having bilateral subclavian artery stenosis is very rare. It's very rare. If at all, if it is there, it will not be at the start. It might progress. First one side, then the second side. Which means I automatically will have a diagnosis. Then I can say it's a progression of the Takayasu arthritis. Fine. Okay. Fine. It's a pulseless disease. That's the other name for Takayasu arthritis. Now I have to prove. For me, for proof, there are two possible things for me. One is biopsy. The other is radiology, or like I say, angiogram. Which you think is better and which you think is easy? Is it easy to take a biopsy of a subclavian artery? It's not, right? Because we don't even know the relations of subclavian artery. And as a big artery, it's very difficult to take a biopsy. So radiology or angiogram is definitely much more useful than a biopsy. So what I see in angiogram is stenosis. Robbins has an image of angiogram picture of subclavian artery stenosis. I'll show the same image and I'll try to explain it. Biopsy will be generally post-mortem if the patient dies for examination, or very rarely, right? If at all a biopsy is being done. It's chronic inflammation. What's a microscopy? You should answer it, right? You should answer like this. Very simple. What do you think will be the microscope? Giant cell, fragmented or broken internal elastic lamina. That's all. It doesn't change, right? It'll be same granuloma. It'll be same giant cell. It'll be same broken or fragmented internal elastic lamina. It will not even a single difference will be there from the giant cell arteritis microscopy from Takayasu arteritis microscopy, right? Treatment here the treatment should be bit same. Inflammatory problem, steroids or immunosuppressant the treatment. Here I need to go bit more aggressive treatment. We need to treat the patient aggressively. We have few drugs called as azathioprine. You will read about azathioprine and others when you come to pharmacology. They are a bit more powerful immunosuppressant, that's all. Like steroids only, a little bit more powerful, because these Takayasu arteritis can involve the CNS vessels very commonly. I should not let that happen. So we go for a little bit of an aggressive treatment, right? We have something called as azathioprine. You will read about much about immunosuppressants in the future. Yes, steroids can also be given. Ultimately, it is about immunosuppression. When you suppress immunity by whatever it is, the inflammation will be reduced, obviously the damage can be reduced, right? Because it can spread a lot, it can involve CNS vessels. I go for an aggressive method of treatment, right? Perfect. Now I have a problem statement. I'm going to tell you the problem statement. Put your pens down and listen to me. Both of these, Takayasu arthritis and giant cell arthritis, are large vessel vasculitis, right? Am I right in saying that a Takayasu arthritis can involve superficial temporal artery, maxillary artery, and ophthalmic artery? Yes, can. Can a giant cell arthritis involve the subclavian artery and aorta? Obviously, it can, right? It definitely can, it definitely will. Because this is the common method of presentation. It can and it will. Whatever we are reading is a common method. It's a large vessel. I cannot tell my Takayasu arthritis, see my textbook is told involve subclavian artery, involve only that. Both of them can involve any large vessel in the body because a large vessel vasculitis, that's all. So the way to differentiate for me is radiology will not help me to differentiate. Both of them stenosis only at the end of the day. Microscopy will not help me to differentiate. Both of them granuloma only at the end of the day. So the way of differentiation is simple: age. If a patient is less than 50 years with classical large vessel vasculitis, be it temporal, maxillary, ophthalmic, subclavian, whatever it is, right? Less than 50 years, that's all. The pathogen is different, same. The name is only different, right? Less than 50 years, any large vessel vasculitis, okay, it is Takayasu. More than 50 years, any large vessel vasculitis, it is temporal arteritis or giant cell vasculitis. So which means 1 year in an exam I can ask you giant cell arteritis. Next year if I want to confuse you, I won't change anything. I will change the age. That's enough. If I change the age, the entire diagnosis changes. The next question is, why should I know this? The simple reason of knowing this is, like I said, Takayasu arthritis is a bit more of an aggressive disorder. I use powerful immunosuppressants. For a giant cell arthritis, steroids is more than enough. So treatment slightly differs. So we need to know this, and there's the only clue for us to differentiate a Takayasu arthritis from a giant cell arthritis. Right? It's a very simple way, but age is also important. Please don't ignore them. Can I say Takayasu arthritis can also have your body pain? Can have, right? ESR elevated, CRP elevated, can have for sure. It's an inflammatory disorder, it can definitely have, right? It'll mimic except for the age, right? The image from Robbins, your arch of aorta. This is an angiogram, okay? That's your arch of aorta. The white color is the dye. If white color is there, dye is definitely gone. Can I say beyond this point, the dye penetration is very less? Which point you want me to repeat with the dye penetration is less, right? Same time in this area, can I say dye penetration is less? Whenever there's a less dye, which means that's an stenotic area. Less dye, which means that area is undergoing stenosis. That's why the dye is not going completely, which means it's the entire thing is having fibrotic lamina, right? Okay. This is again an image from Robbins. On postmortem, when you have a cut surface, look at the lumen. Lumen of a subclavian artery is very small. Subclavian artery is a large vessel, right? So it's completely obstructed by fibrosis. That's why you have stenosis, right? Yeah, that's all. That is fine. Okay. So that's how stenosis looks in a gross examination. Okay. Microscopy I'm not giving. No. Giant cell arthritis will not cause Takayasu. See, both are two different disorders. I'm saying that both are large vessel vasculitis. So both of them can be involved in any large vessel. If it's less than 50 years, any large vessel vasculitis, I'm going to call them Takayasu and treat them as Takayasu. If the presentation is at more than 50 years, okay, I think you got confused here. This is the age of presentation. It's not in general, it's the age of presentation. If a person presents at less than 50 years, I'm going to treat them as Takayasu. If the person lives for more than 50 years also, it will be treated as Takayasu only. If the age of presentation is more than 50 years, I treat them as giant cell vasculitis. I hope that's clear with you. Fine. Okay. So we know about two large vessel vasculitis, right? Now we'll go to one small vessel vasculitis, medium vessel vasculitis. There are two medium vessel vasculitis. I will not talk much about Kawasaki disease. I'll just show you an image that should be more than enough, because Kawasaki disease is totally an clinical diagnosis. When you come to pediatrics, if you're lucky, you might see Kawasaki disease. I don't have anything in microscopy to learn about Kawasaki disease. I'll show in classical examination finding and one of the complications I'll talk about, right? But definitely we'll talk in detail about PAN. PAN is polyarteritis nodosa. The etiology of PAN is hepatitis. The chronic hepatitis B virus is the etiology of PAN. Okay. Sorry. So chronic hepatitis B virus is the etiology of polyarteritis nodosa, right? There's only one thing here. Any hepatitis when it's chronic, or any viral infection when it's chronic, the virus will not be actively dividing. Some point of time, whenever immunity drops, virus becomes active again. Most of the time, this is very dormant. Have you read about herpes zoster? Have you read about herpes zoster? It's a condition which happens. Chickenpox. You must have heard about chickenpox, right? So chickenpox, what happens is, when you have a chickenpox, the virus stays in your nerve forever. It will be then the ganglion forever. When your immunity drops, the chickenpox virus can come back as herpes zoster. You'll read it's a latent infection, that's all, right? Perfect. So most of the virus lacks like that. They are very dormant, they are very latent. Whenever immunity drops, it becomes more active, right? So in other words, why I want this is, in hepatitis, the same thing happens. When I look at the viral titers, random image here, let's assume it's always in baseline. When I say baseline, it's latent or it's a dormant infection. They are not more at all. Whenever the person's immunity falls, the virus starts replicating. As a peak, again immunity will come back and the virus becomes dormant again. Again, when the immunity falls, it becomes a peak, again it becomes dormant again. This is how in any viral infection will be affected. Okay, this is how any virus will be affected. It will always be a waxing and a waning course. It will never be uniform. It will never be same, right? Now, when the virus is in baseline, only liver is affected because it's an hepatitis virus, right? But when the virus divides, am I right in saying that the antigens of the virus can go into the blood circulation? Is that statement right? Dividing. If it's actively dividing, is there a possibility the blood circulation can have virus antigens or virus also? It can, right? So during this active stage of division, during only these stages, it will affect the vessel. It deposits in the vessel wall. When it deposits in vessel wall, it causes vasculitis. Okay. If you understood this, tell okay. If not, I'll repeat, because this is very important for me to understand the microscopy of PAN, right? Here, which means I will have a vasculitis here. During this time, when there's a dormant thing, when there's a latent infection, will you have vasculitis or not? The virus is in baseline. Will there be an evidence of vasculitis when the virus is in baseline or not? You won't have, right? Let's assume here I had the first episode of vasculitis. Then in between, there'll be no evidence of vasculitis. E bar overs, no evidence of vasculitis. Again, in this area, I had the second episode of vasculitis. Again, becomes no evidence of vasculitis, right? So this is what the patient's cycle is. Whenever there's a multiplication, it will cause vasculitis. Whenever there's no multiplication, there'll be no vasculitis, right? Now let's look at the vessel. It's now Just listen carefully and answer this question. This pathogenesis here, it is two episodes of acute inflammation or chronic inflammation. How do you categorize them? Will you categorize them as chronic inflammation, or you will categorize them as two episodes of acute inflammation? It is two episodes of acute inflammation, because in between this latent time can be like 1 year or 2 year or 5 years also, right? It's two episodes of acute inflammation. You had a sore throat today, you can have a sore throat after 5 years. I will call it a two separate thing. I will not call it a chronic sore throat, right? So these are two episodes of acute inflammation, right? Let's keep that in mind. Let's say that I have a vessel here, and in this vessel I'm having a first episode of acute inflammation. Can it cause fibrinoid necrosis? Vessel wall necrosis, can it cause? It will obviously cause, right? Let's assume here I'm just drawing here, it causes necrosis. Acute inflammation, right? It can cause necrosis. This no evidence, I'm just giving you a random thing. It is like 1 year. For 1 year, there is no spike again. Will this necrosis heal, or it will stay as necrosis? Will it heal or it won't? It will heal, right? So slowly what happens is the vessel will heal. It will definitely heal. Healing is always by only 1%. Little bit of fibrosis, scar formation will definitely be there. Again, after 1 year, the second episode came. I'll draw the same vessel here. Am I right in saying that here I'll have the scar tissue here, fibrotic scar tissue, because the necrosis here has healed here, right? So this scar will be there. Second time an acute inflammation happened, can I have necrosis again? You will have necrosis again. Let's say there's necrosis again, right? So when I take this biopsy, when I look at this biopsy, in the microscopy, I'll have both necrosis, that's an acute event, and a healed tissue, that's a scar formation. In a normal pathogenesis, can I see both necrosis and scar at the same time or in different time? In any disease, will you see both necrosis and scar at the same time, or you'll see them in different time? You will see them in different point of time, right? But here I will see both necrosis, which is an acute event, and scar formation, which is a healed tissue, at the same time. So this is very, very classical for PAN. This is called as an temporally dissimilar lesions. Okay, the temporal dissimilar lesions or dissimilarity is diagnostic of PAN. This is very, very important. That's how you diagnose PAN. Temporal dissimilarity of lesions, right? Have you understood? If yes, tell yes. If not, ask me to repeat. I will repeat, because this I want you to remember. Any disease of PAN you're going to diagnose from today onwards is based on the temporal dissimilarity. This word is seen, I know it is PAN. I will see both acute as well as I will see an healed tissue at the same time, the same vessel on the same person. I call it diagnostic of PAN. Fine. That's a pathogenesis of PAN. I'll just repeat it for our sake. Chronic hepatitis B. Normally the virus is latent. Whenever there's a spike or reduced immunity, it spikes, it grows, it divides. Whenever it divides, the virus goes and deposits in the vessel wall, causes vasculitis. In between time, it will have no vasculitis. Only during the spike, there will be vasculitis. In the first spike, there's necrosis. It will heal. Second spike, I will see the scar plus necrosis. When you see in microscopy both necrosis and scar tissue, which is temporal is time-wise dissimilar lesions at the same time you see, I call it PAN. Fine. This is a pathogenesis of PAN, right? Now here, I need to know the clinical features. Okay. There are few. See, I don't like mnemonics because I told you before as well, I cannot create mnemonics, so I hate mnemonics, right? Sometimes mnemonics are misleading. There's a mnemonic which says that PAN, PAN, pulmonary artery not involved. That's a wrong mnemonic. Lungs are not involved, pulmonary artery is involved. You'll ask me what's the difference. There is a difference. That's what is diagnostic of PAN, right? There are two things in PAN. When you take renal involvement, renal failure, is seen in pan, and pulmonary artery, when you take lungs, the pulmonary artery and the bronchial artery are involved. Okay? It is involved in pan. The same textbook, be it Harrison or Robbins or any textbook, will also say that there will be no evidence of glomerulonephritis, and also will say that there will be no evidence of lung parenchymal involvement. Okay? Both of them will be given in any good textbook you see, right? So why is this distinction? And both of them are true. There will be no evidence of glomerulonephritis, no evidence of lung parenchymal involvement, but yes, pulmonary artery is involved, renal failure is seen. PAN, medium vessel vasculitis or small vessel vasculitis or large vessel vasculitis. What is PAN? Medium vessel, small vessel or large vessel? PAN is medium vessel vasculitis, right? Perfect. What is glomerulus? What is glomerulus? Glomerulus is capillary. What does lung parenchyma have? Capillary or medium vessel? Capillary. Can a medium vessel vasculitis involve capillary? They cannot, they won't. That's why glomerulus is not involved, renal parenchyma is not involved, because PAN is a medium vessel vasculitis, will not involve capillaries. As simple as that, right? There's no evidence of glomerulonephritis because it's a medium vessel vasculitis and these both have capillaries. In other words, capillaries are not involved. It's a straightforward statement, right? When capillaries are not involved, glomerulus will not be involved, lung parenchyma will not be involved. Now tell me, in kidney, renal artery, is it a medium sized vessel? It is. Renal failure is seen because renal artery is involved. It's a medium vessel. Pulmonary artery, medium vessel. Bronchial artery, medium vessel. So here this will be affected because medium sized vessel will be affected. Because in medium vessel vasculitis, right? There's no rocket science behind this. PAN is a medium vessel vasculitis. It will involve renal artery, pulmonary artery, bronchial artery. It will not involve lung parenchyma, which has capillaries, glomerulus, which has capillaries. That's all, right? That's a clinical picture of PAN. Most of the medium-sized vessels will be affected and it will cause failure of that particular organ, right? Next. So when you take a biopsy here, microscopy, PAN causes transmural fibrinoid necrosis. What does transmural mean? It causes transmural fibrinoid necrosis. What do you mean by the term transmural? Transmural is full thickness. Intima, media, adventitia entirely will be involved. At the same time, PAN will have, like I said before again, will have the temporal dissimilar lesions. Okay? Now, temporally dissimilar lesions that also will be seen in PAN. Okay? Third, I want you guys to answer. Will PAN have granuloma or not? Because that's an MCQ. You just need to know about the disease. You'll know every MCQ. Will PAN have granuloma? Perfect. There'll be no granuloma. See, because PAN is an acute inflammation, right? It's 2 episodes of acute inflammation. Acute inflammation will not have granuloma formation, as simple as that, right? There'll be no granuloma, temporally dissimilar lesions, and transmural thing, right? Next, PAN in serology or in your biopsy, there are a few marker studies. Okay? HBsAg will be positive. HBsAg stands for hepatitis B surface antigen. That's what HBsAg is. You will remember HBsAg once you finish virology and hepatitis, right? That will definitely be positive. And PAN is ANCA negative. We read about ANCA somewhere in your neutrophilic extracellular trap. Remember them? ANCA is anti-neutrophilic neutrophilic cytoplasmic antibody. Fine. Anti-neutrophilic cytoplasmic antibody. It's ANCA negative. I can explain why ANCA negative. Just give me some time. You need not memorize it. Hepatitis B antigen being positive, you'll definitely know because that's a etiology. HPCIG should be positive. Robin says that somewhere around 30% is positive, but there are like 60-70% positive in recent studies. When we start investigating more and more of hepatitis in pan cases, we find them positivity. Maybe in future it might become 100% positive as well. Fine, we'll see about ANCA very soon, right? And I'll tell you, and you will tell me why ANCA is not seen in pan. It's a classical thing, it cannot be seen in pan. Fine. Next go to, this is an image from Robbins. This is the necrotic area. You can see complete pink color, right? Complete shades of pink color, necrotic area. And this is the uninvolved normal area. At the same time, this part, the lumen is very small, like stenotic, which means there's fibrosis here, there's necrosis, there's normal. Temporally dissimilar lesion, diagnostic of pan or polyarteritis nodosa. Fine. Okay. Next one. Just one more vasculitis. After this, we'll call it a day. Like I said, Kawasaki, I'm not going to talk about Kawasaki. Only one thing in Kawasaki, strawberry tongue. Strawberry tongue is classical for Kawasaki disease. I want you to remember the red color appearance of tongue. And Kawasaki disease is one complication in Kawasaki disease. The complication of Kawasaki disease is about Kawasaki. It's a completely clinical diagnosis. I'm not going to take much time off that, right? There's myocardial aneurysm. It's also medium muscular vasculitis. Patient might have a myocardial aneurysm. These are seen in children, right? They're seen in children. Children having myocardial aneurysm and heart attack is a very unusual complication of Kawasaki disease. That's all about Kawasaki disease, right? Next is about one more disease, vaginous granulomatosis. Small, medium, or large. So when I say we'll stop, you will become more excited, right? Small, medium, or large. Small muscular vasculitis, because we never read them in large and medium muscular vasculitis, so it has to be small muscular vasculitis, right? Robbins must have given a new name for this. The other name for this is granulomatosis. Is my voice dropping again and again? I thought since no one complained, I thought voice is not dropping. Hello. Is my voice okay? Okay. So it's granulomatosis with polyangiitis. This is a newer name for vaginous granulomatosis. Granulomatosis with polyangiitis, right? That's a newer name. You must have read as GPA. Granulomatosis with polyangiitis, right? It's a different name, that's all. Because vaginous was not wasn't a Nazi supporter. So since it was Nazi supporter, Americans wants to remove his name. It's fine. That's a political agenda. Both means one and the same for me, right? Vaginous granulomatosis, like you said, it's a small vessel vasculitis. Most of the small vessel vasculitis, the pathogenesis is one and the same. Pathogens of almost every small vessel vasculitis is ANCA mediated vasculitis, right? If you look at Robbins, they will start with pathogenesis first. I'm using the pathogenesis with the respective diseases so that it's much more clear for us in understanding, right? Most of them are ANCA mediated vasculitis, right? There are two types of ANCA. We'll understand what is ANCA first, then we'll go to the pathogenic model. ANCA, like I said, is anti-neutrophilic cytoplasmic antibody. What do you have in neutrophil cytoplasm? What is there in neutrophil cytoplasm? Whatever comes to your mind. Whatever comes to your mind, what is there in neutrophil cytoplasm? Granules, right? That's all. So this antibody is directed against cytoplasmic granule of neutrophil. If I say granule of neutrophil, what is the one enzyme which comes to your mind? Because that's an enzyme which was involved in your, I'm sure you know that, the respiratory burst and every inflammatory pathway. What enzyme comes to your mind? Myeloperoxidase. You remember that guy, right? So I'm going to have antibodies against neutrophil granules. Granzyme is a granule content, but myeloperoxidase is something much more common, right? So we divided ANCA into two types of ANCA. PR3 ANCA. Okay, PR3 ANCA is called as proteinase 3 ANCA, where the antibodies against proteinase, which is a neutrophil granule content. This antibodies against myeloperoxidase, which is also a neutrophil granule content. That's all. So I'm having antibodies against granule content of neutrophils. This is a new term. The older term of PR3 ANCA was C ANCA. The older term of MPO ANCA was P ANCA, right? I don't use them, but still, if a senior is going to ask you in a Viva, they might ask C ANCA and P ANCA. As of now, when a ANCA report comes to my lab, we report them as PR3 ANCA and MPO ANCA only, fine? So this is what ANCA means. What the antibodies there in this patient is ANCA mediated, right? Now let's take a vessel. I want your involvement here to understand what happens in ANCA mediated vasculitis, right? There's a normal vessel here. I'm having a beautiful neutrophil with granules, which is MPO, PR3, everything. So this patient has antibodies or ANCA in his blood circulation, right? Which means antibodies will be here. Am I right in saying that? If a patient is predisposed to anything, antibodies will be in the serum, right? The autoantibodies here is in the serum, be it C ANCA or P ANCA. Now tell me, is there a possibility this antibody can enter into the neutrophil and bind to MPO and destroy it? Or whenever the MPO comes outside, the antibody will bind and destroy? Which is possible? Can an antibody enter, or the MPO should come outside? How do you think the pathogens happens? The first thing or second thing? The MPO should come outside, right? Because an antibody can never enter a cell. Dr. Mamta must have talked about immunology. Most of the plasma cells, antibodies for extracellular pathogen. Intracellular, it will not affect. Antibody cannot go into a cell, right? So which means even if the patient has antibody in the serum, it will not cause a disease. It will cause a disease only when the granules come outside. When do you think granules come outside? Normally, will neutrophil granules come outside, or when there's an inflammation, neutrophil granule come outside? Perfect, right? So whenever there's an inflammation, any inflammation will obviously result in degranulation. When a degranulation happens, that's a time the antibodies will exit. Sorry, the MPO or my granule content come outside, right? Whenever the granule contents come outside, and that's the time the antibody binds to the granule contents. When it binds to the granule contents, that's my MPO or PR3, which will cause vasculitis. Okay. Now, going back to your acute inflammation chapter, where do you think diapedesis or destruction of by basement membrane or rolling or adhesion will happen? In small vessels or medium vessels or large vessels? Where do you think it will happen? Small, medium or large vessels? It will happen only in small vessels, right? I wish it will happen in your pre or post capillary venules. It will happen mostly in your post capillary venules only, because only in the venules this diabetes, everything will happen. That's what we read in inflammation chapter itself, right? So this degranulation or any inflammation related degranulation is possible. This happens only in small vessels, the post capillary venules, right? So if it happens only in small vessel, will ANCA cause a medium vessel vasculitis? Or it will cause only small vessel vasculitis? It will cause only small vessel vasculitis. That's why PAN is negative for ANCA. Don't memorize it. It's a very pure logic. I'm having this degranulation only in a tiny vessel. So venules, capillaries will be affected. I might not have a medium vessel or a large vessel being affected, because the entire process, the pathogenesis happens only in this vessel, right? So this is the pathogenesis of almost every small vessel vasculitis. Some will have P and K, some might have C and K. Vaginous have both combination of C and K as well as P and K. This is what happens in every ANCA mediated vasculitis, right? So in vaginous, in case of vaginous or your granulomatosis polyangiitis, GPA, whatever it is, right? So here, the antigen which triggers that is coming from the inhalation route. So vaginous, there's a triad of vaginous. Respiratory system will be involved in vaginous 100%. When I say respiratory system, it starts from nose till the lungs. Vaginous, most of them will have bilateral lung parenchymal involvement. Okay, bilateral lung parenchymal involvement, and most of the time can be close to 90 to 100%. And they'll have cavities on the lung. It will be destroyed. See, the concern is, like I said, something which is inhaling. I'm inhaling something that's triggering inflammation, causing destruction. So will it be acute, chronic, or acute on chronic? Every day I inhale, can every day it cause inflammation? It can, right? So it's an acute on chronic. So definitely for throughout the year, they'll have repeated damage and destruction. And every time that inhalation antigen which is being inhaled, which will trigger and cause more and more damage. So definitely it'll keep on destroying. Without respiratory involvement, vaginous can never ever happen, right? And in the vessels, they'll have necrotizing granulomas. It's an acute and chronic problem, right? You'll have granulomas, at the same time you'll have necros as well, necrotizing granulomas. Can vaginous, which is small vessel vasculitis, involve glomerulus? Possible, not possible? It is possible, right? It's definitely possible. It can involve glomerulus. In glomerulus, it especially causes a type of glomerulonephritis called as crescentic glomerulonephritis. Okay, it's possible for the only reason it's a small vessel vasculitis. Glomerulus is a capillary. Definitely, it can involve glomerulus. Subtype called as crescentic glomerulonephritis. When we go to kidney chapter, we'll definitely read in detail about crescentic glomerulonephritis, right? Okay, so this is a triad of vaginous. Like I said, can involve from nose to lungs. When you go to ENT, vaginous can cause nasal septal perforation. It's one of the causes of nasal septal perforation. It can destroy anything from nose till my lungs. Anything in the respiratory tract can be involved by vaginous, and have necrotizing granuloma and have your crescentic glomerulonephritis. It's a triad of vaginous, right? There are few things called as limited vaginous granulomatosis. When I say limited, if only, I'll tell you this, just give me a second. If only respiratory tract is involved, there's no involvement of lungs or any other organ systems, I call it limited vaginous granulomatosis or limited granulomatosis with polyangiitis, right? Okay. So I'm having an autoantibody formation against MPO, right? Something must have triggered this antibody, right? If you remember a template for any autoimmune disorder, there must be a trigger, a virus. If you remember Sjogren's syndrome, I said some virus can trigger new antigen formation. So that trigger here comes from a respiratory route. So whenever that trigger, I don't know what antigen is causing that, something from inhalation is triggering the autoimmune formation, produces more and more antibody and destroys everything, right? That trigger is coming from the respiratory route. That's all. Okay. Fine. So vaginous serology, when it comes to ANCA positivity, vaginous is PR3 ANCA positive. 100% of vaginous will be positive for PR3 ANCA. MPO ANCA will also be positive. Like I said, it's dual positivity, but NPO ANCA positivity is around like 30-35%, not more than that. So if you have a question which says both are positive, I would prefer you to choose both. If it's only one to choose, definitely PR3 ANCA or C ANCA will be the best way to choose your positivity. Fine. Okay. Treatment, like I said, I will leave it to your medicine person. They'll tell you how to exactly treat it, because vaginous has put on like I have to treat my lung or my glomerulus. It depends on the involvement or the severity, and based on that, it's primarily in your immunosuppressant only. What group, when to start, when to increase the dose, everything will be told in medicine, right? There's an image in Robbins, cavity. If a vasculitis can cause cavity in the lung, first thing, think of vaginous or your granulomatous with polyangiitis, right? I'll just zoom this image. What are you seeing here? Or this one, what are you seeing there? Cells with multiple blue dots, that's your Jane cell, right? So you'll have Jane cells, that's your granulomas, Jane cells, and vasculitis. Okay, you have Jane cells and granulomas, and you have destruction of the lung parenchyma, which suits for your vaginous granulomatosis. Fine. So that's about vaginous granulomatosis. So I'll stop, like I said, I'll stop with this vaginous. There is little bit more thing. There are 3-4 more vasculitis we'll see in the next class. What you have seen in this today's classes, we have completed your aneurysms, dissection, and also we have kickstarted vasculitis, right? Though your CBMA curriculum is not involving vasculitis, I don't know whether they'll teach you in the class, but to understand and for competitive exam, vasculitis is more important than atherosclerosis and aneurysms, right? So if any doubt, do let me know. If not, we'll call it a day.